Good morning. Welcome to our 5th annual Center for Emerging and Neglected Diseases Symposium. Thank you all for coming here, and hopefully you'll stay the whole day. We have a great program today. So putting a meeting like this, symposium like this together requires a lot of work behind the scenes. And so I don't forget, I want to thank Zalosi Lyons. Where are you, Zalosi? You're probably out there. Oh, I guess I don't have to thank her then. No, it's Zalosi who has done so much work putting this together. This has been a bit of a transitional period in SEND. As many of you appreciate, SEND started about 5 years ago with an endowment from Sam Wheeler, a 20-year endowment, so we're not going away. And SEND does a lot of things. We've included a folder today that has some information. So, for example, people say, what is SEND and what does it do? So we try to answer that today with a pamphlet that you can read. From the beginning of SEND, it was started by Jeff Owen, the former Dean of Biological Sciences, and Jeff is still involved. And the executive director for the last 5 years has been Tamina Madden. And Tamina has been amazing. She really has been the force behind SEND. She's worked tirelessly. She's passionate. She's incredibly effective. And we really appreciate her contribution. And Tamina is moving on. But I'd like to thank you, Tamina. But this last year, we had a nationwide search to replace Tamina, and we were lucky that we were able to recruit Elizabeth Ponder, who is now the executive director of SEND, and many of you have already heard from her, and if you haven't, you probably will. And so let me tell you just a very little bit about Beth. Beth has had a long interest in infectious diseases and global health, and got her PhD and postdoc at Stanford, where she worked in various areas, including malaria and therapeutics. And then after that, she's been working at BioVentures for public health and has started as of the first of the year. So let's put a name with a face. Beth, let them see who you are. Okay. And so every year we've been fortunate to have a volunteer faculty member to chair this meeting. And today, this meeting has been put together by Britt Glausinger. And so Britt will be running the show today and was involved in inviting most of the speakers. And as you can see, we have a really eclectic and esteemed group of speakers today. So it should be a great day. During the meeting today, we're going to have microphones being passed around. So when you ask a question, please wait for the microphone. This meeting is being filmed, videotaped, and so this will all be online eventually, and if you're not speaking in the microphone, the question will not be audible. Okay, so we're going to start out. Luke Lee is going to introduce our first speaker. And thank you all for coming.
Thank you for all coming here, and this is a really exciting time that I'd like to introduce the first speaker. His name is Madhukar Pais from McGill University. I met him at the meeting, Gates Foundation meeting at India, and I didn't know that he got a PhD from Berkeley. This is fantastic outcome from Berkeley Public Health. He has both MD and PhD, and he finished, as I mentioned, the PhD in Berkeley, and also a postdoctoral fellowship at UC San Francisco. He's currently associate professor of epidemiology at McGill University. I hope you can see all the detail, but he's, what I really was impressed with, he has a clear understanding of both public health, medical issue, and engineering issue. So I felt that you can really hear his excellent talk and then get a better understanding of what is the need for TB, because his focus is TB, and hopefully engineers as well as physical scientists or chemists and work together with the public health by listening his wonderful wisdom. Let's welcome Madhukar.
Good morning. Can you hear me okay? It is such an honor to be invited back to the same school where you trained. As you often know, you get least respect in your own house. It's like you're world famous, but your mom still thinks you need help tying your shoelace, kind of a phenomenon. So it is fantastic to be back, and I just cannot believe it that it is 12 years ago that my wife and I got on a plane from India to come to US for the first time, straight to Berkeley. And the man who gave us the biggest break in our careers is sitting here, our Rheingold. That changed our lives, and as the saying goes, we've never looked back from that time. So it's quite an emotional time for me to be coming back to my own school. So I spent the last day, yesterday, the whole day at Stanford, giving 2 talks, including the inaugural Ellen Jo Barron lecture. Ellen Jo is here at Stanford. And it is such a big contrast to go from Stanford to Berkeley. I gotta tell you, soon as the BART crossed the bay and entered downtown Berkeley, I started breathing again. I said, this is like India. I can live here, you know? Stanford is too clean for me, you know? It's too perfect. Yesterday, I mean, we had a very interesting Cal-Stanford battle going on in Stanford. The chair of pathology took me on and said some bad things about Berkeley, so I had to defend Berkeley, so this is what I told them. I said, something needs to be done about Stanford. It's too perfect. So I said, call in Berkeley troops. We'll come and make it a little bit more livable, right? So my work is all about TB and diagnostics, and I'm here to share some insights from the work that we are doing. Before I move ahead, just a few disclosures. I have no financial or industry investments in any diagnostic technology. I do serve as a consultant for the Bill and Melinda Gates Foundation, and I'm also a grantee of the Gates Foundation. So my role is to really get into the issue of point-of-care testing. And I'm just struck by how many young people here at Berkeley, I mean, SEN didn't exist when I was here. And I never saw this degree of interest among engineers and bioengineers and chemists in solving global health problems the way I see it here today. And not just here at Stanford, at UCSF, and Bay Area biotech companies. There's just such a vibrant groups here working on global health, and diagnostics is definitely on the list. Can I just get a show of hands? How many are interested in diagnostics-related issues? Wow, this is amazing. Didn't happen during my days. My PhD thesis, as Art will tell you and Dee will tell you, was entirely on diagnostics, but there weren't too many people those days looking into those issues. And I interact with industries a lot because they all contact me about TB diagnostics, and they say, we're working on a point-of-care test. And it's often very unhelpful for me to just get that catch-all phrase. We're working on a point-of-care test. So I say, what exactly are you talking about? Because it's not clear to me if you just say point-of-care testing. And I think each of us who are working on diagnostics is carrying some vague notion of what we think point-of-care tests or point-of-care testing is. But I'm not convinced we all have a very clear shared understanding of that phrase. And the commonest thing I have heard, and I'm sure this will resonate with many of you, is that point-of-care testing is a cheap dipstick that you do under a tree. That's the most common paradigm that I've seen. It should cost pennies. It should be equipment-free. It should be really, really simple and dumbed down. It should be something you can do in the bush under a tree, in a mobile clinic, or somewhere out there, right? And that it should meet all of these criteria, these assured criteria that WHO proposed years ago, that it should be cheap, it should be equipment-free, so on and so forth. And it should be done outside of a lab. It should be done by not trained people or minimally trained people. And we really think that this is not really reflective of real world. So my wife and I published this paper in PLOS Medicine. My wife, Nikki, also trained at Berkeley. She's also an MD, PhD. Art was her supervisor. She works on HIV and STI diagnostics. So we are a bit of a diagnostic nerdy family hopefully our 5-year-old will do something better with her life. But we rarely work together, my wife and I, and I'm sure many of you understand why that will be. The only original contribution we have made is our kid. That was a true joint first authored publication. Other than that, we generally don't publish. But this is something we did because her work was all on point-of-care HIV STI tests, where she's published a lot. And she works on HIV self-testing and those things, and I work on TB. So very rarely we agree on something, but this is one thing we did agree on. So we proposed and essentially challenged this dipstick under a tree paradigm. And the paper is all about what we think point-of-care testing is. We're not saying it's a right or the only way to look at point-of-care testing, but we felt that the field will benefit from a more zoomed-out perspective than just that narrow piece that most people think point-of-care testing is. So there are many, many definitions in the literature on point-of-care testing. I'm sure each of you has seen one. You have your own favorite one. For the sake of this paper, we used this one that we liked. This is by Chris Pais in a book published in 2004, where he says, point-of-care testing can be defined as the provision of a test when the result will be used to make a decision and to take appropriate action, which will then lead to an improved health outcome. You know why I personally like this definition? Because it does not say a lot of things. It does not say anything about the technology or how it should look, does not say what it should cost, it does not say who should do it, where it should be done, what the location is, what the setting is. It is completely agnostic to all of that. That, to me, is genuinely what point-of-care testing is. I want to work from what really matters to me as a clinician, as a public health person, and work my way backwards from the most critical outcome. What I perceive as the most critical outcome is the test should result in a rapid and clinically actionable result. That should then change the provider's behavior, whoever the provider is. That should lead to a correct treatment or management choice. That is the one that will ultimately lead to the patient getting better, ergo, the public health benefit from that process. Now, none of this says anything about technology, what it should look like, who should do it. It is completely agnostic to that. Now, if ideally the first 3 boxes, test being done, provider changes his or her behavior, correct treatment is given, if all of that happens on the spot, whatever that means, in the same clinical encounter, which I think is a more bankable phrase, at the very least, while the patient waits until the end of the same day. If can it all happen in that period, to me, that completes the point-of-care testing loop. So I'm now going to reshape that into what I call the test and treat loop. Completion of this test and treat loop in the same clinical encounter, worst case scenario, on the same day before the patient goes home, to me, is completion of the point-of-care testing paradigm. Patient is seen, test is ordered, test is done, results are rapidly reported, and a treatment is given. When I say test and treat, I'm putting treat within double quotes, because treat sometimes could be starting a drug, stopping a drug. You know what? You don't have the disease, stop the drug, or modify the drug. You actually have drug-resistant TB, not the regular TB. I'm going to change your drug regimen. Or refer. You know what? You need to go to another center now because this is just not the right place to treat you. You need to be pushed up in the hierarchy. Or you need another test. Your preliminary test is positive. I'm now going to ask for another test to confirm what you have. Or discharge. You know what? You're done. You're cured. Go home. You don't need to be in isolation. Or to admit, you have a serious problem. You need to be in bed right away. Any and all of these are management decisions that point-of-care testing can support. So this test and treat paradigm, if it is completed in the same clinical encounter, that is the ultimate goal of point-of-care testing. This is where clinical impact will come from. This is how you reduce transmission in the community to somebody else, and therefore the public health benefit is there. Nowhere here does it really say who's doing it, what is the test, who is the user, is it lab, is it not the lab? None of that really matters here. This paradigm is what we try to present in this particular paper. Now, in TB, which is my field, there are 2 numbers that I really care about as a public health person. time from the patient becoming infectious, after they've been coughing for how many ever days, to the first dose of anti-TB drugs. I think Lalita is in the audience. People like her will tell you what the reduction in infectiousness will be with just a single dose of anti-TB drugs. One dose has a dramatic effect on reducing the infectiousness of the person. So the first pill is swallowed, first set of pills are swallowed. We've already made a breakthrough in reducing transmission in the community. But that number is impossible to estimate because nobody really knows when somebody really becomes infectious in TB. Right? There is no way to even measure that metric. And it is also confounded by delays in seeking care. In countries like India, people cough for days and weeks before they actually seek care. That's a big problem that no point-of-care testing can really solve. Right? So this is a great and critical number, but we really can't get hold of this that easily. But the second number we can do something about. Time from the patient presenting at a health facility to the first dose of anti-TB drugs. Cutting this interval to the barest minimum it can ever become is one of the most important goals of point-of-care testing. Eventually, people do get picked up with a smear weeks later, months later, and eventually they do get treated. But it is too late epidemiologically because they've ended up transmitting the infection to at least 15 plus people. And therefore, the cycle of the TB epidemic keeps continuing. And I think all healthcare programs and national TB programs must keep a careful watch on this number. What is the time, from the time a patient is knocked on your clinic or your doorstep to the first dose of anti-TB drugs? How can health systems cut that down while they're working on reducing diagnostic delays, which is a whole another problem altogether? This is where I think a point-of-care testing program can make a big impact. So what we proposed in this paper is that point-of-care testing is a genuine spectrum. When people say dipstick under a tree, they're only dealing with one slice of a much longer continuous spectrum. And what we felt that there were at least 5 target product profiles. Test developers and engineers often use this term, TPP, target product profile. It is a combination of who your user is, what your setting is, what does the product look like, where is it done, what is the goal of testing. So we identified 5 TPPs. The first is you test yourself at home. HIV is the only infectious diseases for which this TPP has been met. And the OraQuick test by OraSure is the only technology that I know of which actually fits into every one of these 5 TPPs. There is no other infectious disease test that fits into that paradigm as of now. Here, the goal for testing is that not that you're going to treat yourself with ART, is to seek care, right? But it has to be a layperson who is your user. It has to be the simplest, dumbed-down technology you can possibly come up with. Can you ask someone, go ahead and pipette 2 ml into this and that at home? Right? So the technologist who is developing the test, the minute they define this TPP, they know what they're up against. They know what the technology should look like. They know who the end user is. They know how cheap it should be, so on and so forth. All sorts of restrictions now make sense to me because I have defined my TPP. I know exactly what I need to do to fill that TPP. The second TPP is in the community. Could you do a malaria test in a community where there's no clinic? Absolutely. It's being done right now. Could you do a rapid HIV test? It's being done right now. So here it's a community health worker who's minimally trained. Don't expect that person to do a sophisticated NAT or a molecular test in the community. Don't expect to have biosafety. Keep it simple. Here the goal is often triage and referral. We think you have malaria or HIV. Can you please now go to the health post or a health clinic for your drugs? Occasionally, you could even treat in the community. There are people in India who are treating childhood pneumonia in the villages without even the doctor being there. You could give Septra in the community, and that's being done. There's a third TPP where you're now operating in a clinic. Now you have a little bit more resources. Maybe you have a building. Maybe you have a small attached lab, or maybe you don't. But maybe there's a doctor now. Maybe there's a minimally trained nurse now. Maybe there's power now. Maybe there's electricity now. Therefore, you could probably bump up your technology and do testing at that level. Is it happening? Absolutely. HIV, malaria, syphilis, dengue, strep A, whole bunch of technologies could fit in here. Could you even have a handheld device here? You could. Doesn't have to be a dipstick now because you're now operating in a clinic. What about the peripheral lab? This is such an important TPP that we constantly ignore. That's why I hate it when people say point-of-care testing should not be done in lab. Who says that? There are lots and lots of health centers with a small little lab attached to it. And it is a critical place where testing is happening today. And to not acknowledge that makes no sense to me at all. Strengthening these peripheral labs is a big part of what PEPFAR does, or countries are actually doing, because most of the time, doctors and others are just too darn busy to do any testing. There has to be a little lab with a minimally trained technician to really take charge of diagnostic testing. Expecting doctors to do it or busy nurses to do it just won't cut it, right? And this is an important place. Lots of tests can be done here. Now you can really start bumping up your technology. Could you have a little molecular test? You could, if there's power and the resources. Could you have this technology's pipette? Maybe you can now. But you can't expect them to do that at this level. All sorts of rich technologies can go into the peripheral lab. But I use the term peripheral lab, not a centralized reference lab. I don't think centralized reference labs really can support point-of-care testing. This has to be attached to some clinic where treatment can be rapidly initiated. The last TPP is, could you do point-of-care testing in hospitals? Who says you can't do it? It's happening every day. You go to the emergency room, kid is presenting with signs of flu. Could you do a rapid test and send the child home on Tamiflu? Absolutely. This is happening all the time. So who says you can't do point-of-care testing in the hospital? Can you not do a handheld ultrasound to diagnose the cause of acute abdomen in the ER? You could. All sorts of technologies can now fit into this hospital paradigm. This is exactly how we've envisioned point-of-care testing. The cheap dipstick is one of these paradigms. But it cannot be confused with all of point-of-care testing. The actual spectrum is much richer than we ever think. So what we proposed is that it's a spectrum, it's a catch-all phrase. One has to commit to a TPP for it to make sense to somebody else. So if you're saying you're developing a point-of-care technology, tell me which TPP you are operating in, then I intuitively know what you're referring to. But without qualifying it further, it's impossible to know which end of the spectrum you're operating and what your actual target product profile is all about. We also said in this paper that technology does not define a point-of-care test, nor determine its use as POC. It is a successful use in a point-of-care program, test and treat strategy, that actually defines a diagnostic process as point-of-care testing. This is often quite difficult for people to understand or swallow. People think that a test, whatever it looks like, should have a label on it which says this is a point-of-care test. We disagree. The technology itself is not point-of-care or point-of-care. It is how it is used that makes it a point-of-care program. You could have the simplest dipstick, but put it in a reference lab and give the results out a week later. Is that point-of-care testing? It's not. So it's not the simplicity of the device that makes it point-of-care. So no technology, in my view, should have a label on it saying this is a point-of-care test. You could say this is amenable to a point-of-care testing program if you make it work like that. So it is how health systems take a technology, make it work as a POC program, or don't make it work as a POC program. So health systems have to make a choice. Are we going to take this rapid test or gene expert or whatever and successfully make it work as a POC program, or we are not going to make it work as a POC program? There's no two ways about it. If you make a commitment to a POC program, you've got to put in everything that is necessary to make it work. I can't say, I'm going to do rapid malaria testing and not have drugs in my pharmacy. I can't say I'm going to do rapid HIV testing, not have linkages to an ART center to complete the loop on the same day. I can't start a POC program and say, I'm only going to see patients in the morning. When the result comes back in the evening, I'm not going to be there. You have to do everything else necessary to actually successfully implement it as a POC program. A system for rapid reporting, ability to act on the results, i.e. availability of drugs, human resources, quality assurance, training, so on and so forth. So POC programs, this is paradoxical to people, can actually cost more because you have to put everything else to make it work as a POC program. The reagent cost may be less, but the program itself may cost more because you may need a second nurse in the evening to look at the results. Your pharmacy may need to stay open till 6 p.m. to make sure drugs are given out that same day. Therefore, the actual cost of a POC program may exceed the cost of the reagents by a big chunk. So let me now ask you, A microscope, standard microscope, is that amenable to a point-of-care testing program? Not a dipstick, not highly portable. Maybe you can lug one in your backpack. But I don't see a microscope necessarily as being something that you'll run around with. But can it be a point-of-care testing program? Absolutely. And I'll give you a great example. I was in rural Karnataka last week. I went to this village. They had a 24/7 primary health center. This is India's biggest source of healthcare. For every 100,000 population in India, there is a primary healthcare center. So I visited this center. There was a MD that day who was seeing a patient with fever. So she said, go to the next room where there's this little lab. Can you believe it? That's all the lab is. It's one table, okay? But at least it has a microscope. There's some slides there and some stains there, and there's a minimally trained technician there. That's her job. She's a full-time technician. This is what I call a peripheral lab. It could be just a workbench, but activity is happening there even today. So she was sent there. That's exactly what she did. She did a thick smear. She read it. Within an hour, the woman went home on chloroquine. This, to me, is point-of-care testing program. Just because it's a microscope, it doesn't mean you can't make it work as a point-of-care testing program. This is a great example of good use of a good technology. And this woman genuinely felt that as a microscopist, her reading of the malaria smear will be better than a rapid test for malaria. Okay? And sometimes they can see things much better than anyone does because that's what she does every day for 10 years. Right? You have to be good at it, right, at some point, even if you weren't when you began with. What about sputum smears? Sputum smear microscopy is the test for TB worldwide for almost 100 years. Is it amenable to a point-of-care testing program? In other words, whatever we did for malaria, could we not do it for TB? Absolutely. Sputum smear microscopy is a point-of-care test. But most NTPs, National TB programs, are not able to make it work as a point-of-care testing program. My country is a phenomenally interesting example of this. India has 13,000 of these peripheral microscopy centers with a trained technician who can do direct Zeal-Nielsen smear with good quality assurance, okay? These technologies are pretty darn good at smear microscopy. It may only have 50 or 60% sensitivity, but they'll do it well. But India, by the time your smear is positive, it can take 8 days before anti-TB treatment is started. There is no mechanism in India to do a stat smear on somebody who is coughing for 2 weeks and send the patient home on TB drugs on the same day. The health system does not make it work as point-of-care testing. And you know what some NTPs do? Come back every day for 3 days and give a sputum sample. Come one day, come another day. You know, it's like half a day or a day lost for a poor patient. Many of them drop out of this testing process. So just because it's a sputum smear and it is amenable to POC doesn't mean it's successfully done as a POC program. Here the program is failing the patients in the way it is setting up smear microscopy. They could make it work, they're not making it work. So our colleagues at UCSF, Luke, Aditya, and others, published this paper which basically say test and treat should be the new standard for smear-positive TB. They're saying at least get smear-positive patients on TB treatment the same day, for Christ's sakes. Don't make them come back 2 days, 3 days later. You have an opportunity to cut transmission. Why are you not using it? Right? WHO has a policy on same-day smear microscopy. Most NTPs are not following this policy because it requires major rechanges in the way they do healthcare delivery systems. Very many places, the doctor is there only in the morning. So if a smear is done and ready by 4 p.m., nobody is there to act on it. These are all health system-related issues, which is not specific to the technology. Can Gene Expert, Dave Persing and Ellen Joe from Cepheid are here, and I gave the same talk at Cepheid 2 days ago. Can you make Expert work as a point-of-care testing program for TB? The answer is absolutely yes. But are programs doing that is the question. Take South Africa. South Africa is one of the first few countries to take Gene Expert and scale it up nationally. But they have put it in a network of centralized testing labs within the National Health Lab System, NHLS. They are not making it work, as of today, as a true point-of-care test. Could they? They could. but they've chosen not to for a whole host of reasons. One of the reasons they've said they're not doing it, they prefer to do it as centralized lab, is that it's very expensive to do it as a point-of-care testing program in South Africa. Centralizing is easier for them, but centralizing means also loss in time. So by the time a result comes back 2-3 days later, the gene expert result is waiting. Nobody in the clinic has opened the email or the folder to actually look at the result. So technology is good, but it's not being made to work as POC. Take a look at this paper. Location of expert in centralized labs in South Africa undermines potential impact. Okay? So that's an example where a test is being scaled up, but not necessarily as a POC program. Take India. I visited India a month ago, and they are making Gene Expert available in busy TB clinics like the one I went. So I went to this clinic in Delhi. The doctor's here. Expert is being done on that table. So I said, this is cool. So is the result coming back? Is the patient going home on TB drugs? No. I said, why not? We were not told to do that. I said, really? Is the clinician not excited about having a test there? Is he not saying, wait for 2 hours, I'll send you home on TB drugs? No, 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 no. The policy is come back after 2 days. So technology is there. It's waiting. Somebody can act on the result. They are not doing that. And it gets much worse, guys. This is a great example that I'm going to give you in a second. A lot of people are now talking about point-of-care Nats, or molecular tests. And again, point-of-care Nat means nothing to me unless I hear from the person where exactly they plan to deploy that point-of-care Nat. Okay? So there are 4 fast follower technologies after Gene Expert that are all now on the market. LAMP, this is an Indian product, Gene Drive, NatEasy. They all think that just because it's small and compact and nice, that is somehow a point-of-care Nat. Smallness or compactness has nothing to do with point-of-care. How you use this NAT in that loop that I just spoke about makes it a point-of-care program. So I spoke to all of these guys who developed these products, and I said, are you sure you can make this run in a peripheral microscopy center in a country like India? I said, yeah, look, it's so small, I can put it in my backpack. I said, that doesn't help me, right? Can you actually extract DNA in one of these microscopy centers? You got to extract the DNA to run it on your little machine, right? How are you going to process infectious sputum? Can you really make it fly in that setting? So I said, what does the setting look like? Have you not gone and looked at this peripheral labs before calling it a point-of-care NAT? So I said, OK, I'll tell you. So one of my students is doing this study. We now have data from 15 out of the 22 highest burden countries. Okay? What does a typical microscopy center look like, really, peripheral lab in an average high burden countries? Okay? So you look at these countries, Afghanistan, Cambodia, so on and so forth. The bottom half is the BRICS countries, okay? Russia, India, Brazil, South Africa, and China. Red means bad news, okay? Green means good news. Yellow means maybe. Take a look at continuous power, okay? Continuous power cannot be banked on in most of these countries. If you had 24/7 power in India, that's big news that day. Because virtually no place in India has 24/7 power, especially these peripheral labs. What about temperature? Your machine can get cooked in India in summer. Right? Have you been to India in summer? 45 Celsius on a good day, okay? And Gene Expert will just blow up. Shouldn't, but it might blow up, okay? So these things are not designed for these sorts of settings. So just because something is small and compact doesn't mean you can successfully deploy it in these microscopy centers where you should be deploying them. Well, what do you have? Do you have a hood? No. Most microscopy centers don't even have a hood. So what biosafety can you do? How can you manipulate sputum on an open bench, right? So technology developers have to look at this and say, what is it that's available? Can we really make our technology work? Because all these 4 technologies require manual sample prep, okay? And they're still saying it's a point-of-care NAT, and I'm asking them how. Where exactly do you plan to make this work as a point-of-care program, right? And then look at this. At some level, you've got to say, is there anything in these places? Well, there are 2 things. All of them are green on a direct Zeal-Nielsen smear. Okay, that much they can do. And all of them have cell phones. They may not have anything else, but they all have cell phones. Okay? That's about the only thing that's lighting up green in this entire chart. okay? Which does tell me that cell phones may have a very important role in rapid reporting of results. If nothing else, we've got to figure out how to use cell phones better just to recall people to complete the point-of-care testing loop. And everybody now has a cell phone. India is just mind-boggling, okay? Everybody and their brother has a cell phone. May not be your fancy iPhone, they've got something that works, okay? And intelligent use of that with technology will be the next wave. So my point here is there are critical issues that influence the impact of NAT. GeneXpert is a great technology, but will it have an impact? Well, it depends entirely on how GeneXpert will or should be used in these countries. What will be the implementation in a passive case detection program? If you wait for people with cough to actually come and seek care, and if that wait time is weeks or days, GeneXpert is not going to reduce TB transmission, okay? The technology is not going to fix that problem. Secondly, if informal and private health sector providers are the most important first contact providers, do you really expect an unqualified practitioner in a village to use an expert? Ellen thinks yes, but I say no, okay? Because you really have to be realistic on who your end user is. Can they be successfully implemented the way I've said, test-treat approach? I already showed you an example that it's not being done like that. And will they be used in all patients with suspected TB, or only a tiny sliver of all patients? India has just said expert will be used only for MDR TB and people living with HIV/AIDS. These are not big groups. These are not the groups where impact will come from. I'm not saying they're not important. I'm saying for cutting down the TB epidemic in India, you really have to go after people with garden variety TB and get them on treatment faster, and India is not going that way for cost reasons as of now. So I want to kind of end by giving you this example. Can a great technology be made to work in a far from point-of-care testing program, okay? This is the line probe assay. It's a WHO-approved tool for MDR TB, very accurate, and it is, at best, a second-day result assay, okay? It's not a rapid test like GeneXpert, so very difficult to do it on the same day, but at least you could have a bankable result for INH and rifampicin resistant by the next day. Take a look at how technologies like this are actually being used. There are 2 studies with identical result. I'm just showing you one. This is from South Africa, okay? Implementation of this line probe assay reduces time to MDR TB treatment initiation in South Africa. That's the title, but I want you to look at the actual numbers. Specimen collection to start of MDR TB treatment, if you do it with liquid culture and drug susceptibility testing, is 80 days, okay? If you used a 2-day line probe assay, that number comes down to 2 months. Yeah, it's better than culture, but still 2 months from specimen collection to start of MDR TB treatment in a high HIV burden country when somebody could die in that 2 months if they had HIV and MDR TB. And then you start taking that 2-month number and you start splitting it, it gets even more exciting. Take a look. Specimen collection to specimen arriving at a lab is 2 days. Can you live with that? Yes? Is that okay? Specimen collection to arriving at your lab is 2 days. Is that okay? No? It's too long? Okay. I could live with that worst case scenario, okay? Because I'm a bit more realistic, okay? I'll live with it, I'll take it, but take a look at the next number. Lab processing time to actually do the line probe assay. I told you it's a 2-day assay. In this South African setting, it is 1 month to actually complete the line probe assay, okay? It's the same NAT that I just told you about. Nothing has changed, okay? And then, this is a killer, guys. Clinic notification of the line probe result. That is, the result has been sent to the clinic where the patient first came. It's there. I don't know in what format, paper, email, it's there. Clinic notification of the result to start of MDR TB treatment is 3 weeks. Altogether, 2 months, okay? So tell me now, which of this is technology and which of it is healthcare system and how healthcare systems are actually using technology, okay? So here, I would actually say it's the program that's let down the patient and not the technology. And often these are confounded, right? You really cannot separate out, which is why I love these sorts of studies. These studies tell me really what's going on. Test sensitivity and specificity of a line probe assay is a useless metric for me. I know it's an accurate assay. How it is actually being done and implemented to have clinical impact is impossible to make out from sensitivity and specificity, which is why we hate sensitivity and specificity. We have a whole advanced course every summer where we don't use those terms. We don't care for them. We want to know what is the clinical and public health impact, and that requires an entirely different study design than just yet another study on sensitivity and specificity. So to summarize, point-of-care testing program has two components. It's the technology, which some of you are working on, and it's an enabling healthcare system. The last example was not an enabling healthcare system. I'm not against South Africa by any chance, okay? India is even worse, okay? I'm not blaming anybody here. I'm just saying how any healthcare system takes a technology, makes it work as a POC, is the defining characteristic of a POC testing program. Or as my friend Peter Small likes to put it, a point-of-care testing program is test plus a business model. How do you really make this work? What economic incentives will drive people to complete it? What are all the necessary pieces you need to make it work? That makes up a business model. And an MBA will tell you that this is something MBAs understand best. Technology alone won't scale up. It's a business model that actually scales up the use of the technology. So there are lots of barriers for establishing point-of-care testing program. Even the simplest dipstick is up against it, okay? Just because you've developed a dipstick, don't breathe easy, okay? Implementing it successfully as a POC requires a whole bunch of other stuff that technologies can't do much about. It's a health system related issue. At some point, the technology hands over the product and has to step back. It's how programs use it that really defines it. So major barriers need to be overcome. For the want of time, I won't walk you through our painful list of barriers, okay? You read the paper, we've given you real examples of barriers at every one of these levels, okay? For the want of time, I'm only going to focus on one barrier, which I think is absolutely critical in my country, India. I'm going to show you this paper, which got published a month ago in Health Affairs. This is a scary paper, okay? If you really want like a horror movie night, open this PDF, sit with your iPad, and read it, okay? It keeps me awake at night. So this is a study where Jishnu Das, a friend of mine, he actually trained people to act as patients, and he sent them into all sorts of clinics in India. Public, private, qualified, unqualified, quacks, not quacks, everybody, okay? In urban and in rural areas. Large, well-done study, okay? They presented with 3 diseases. Unstable angina, oh, I have crushing chest pain, I'm going to die kind of a example. Asthma and dysentery, okay? They were trained to act in these 3 ways. Ethics approval was all obtained, but unannounced, okay? So these providers had no idea who these guys were, and they used local people, because if we went there as patients, they can smell the rat, right? They should look like the average patient. Then, take a look at the result. In a rural area in Madhya Pradesh, the average visit length, consultation time, was 3.5 minutes, okay? In urban Delhi, it's 5.5 minutes. That's the average amount of time practitioners spent with their patients. 67% of rural providers were unqualified. They had no medical degree whatsoever, but they were practicing medicine, okay? And in Delhi, 16% were unqualified. In India, these unqualified providers are called quack doctors, okay? Quack doctors. Now, I'm asking the question, you have a great dipstick or a point-of-care technology. Do you really think this kind of a visit allows you to do any testing? Do these guys even care about testing? If they are making decisions and sending patients home on treatment in 3 minutes, what is the role of diagnosis in that visit, right? That's the question worth asking. So this is a great slide from the same paper. If you had a crushing chest pain, take a look at even the simplest questions that the provider could have asked. Does your pain radiate to your back? It's a simple question that takes half a second. Even that question was not asked in a vast majority of patients. Even a question is not being asked, let alone a point-of-care diagnostic test, okay? And Still, most people gave prescriptions and sent the patient home. So they didn't ask any questions. They spent 3 minutes with the patient, yet they wrote all sorts of prescriptions. Most unnecessary or harmful treatment was given in over half of all patients. Not even vital signs were checked: temperature, pulse, blood pressure. Okay? So my friend and colleague, David Doherty, sent me this email as soon as he read that paper. He said, if less than 50% of providers even listen to someone's heart when they're having chest pain, could we ever expect them to use the simplest dipstick for TB? And he says, there's no difference between asking one of these people and asking your local priest. Neither counts as a true clinical encounter. I said, David, I completely agree with you, right? These guys are not even asking the simplest question. So I'm asking, what is the role of a diagnostic test in such an empiric shotgun practice environment? When somebody is totally bypassing the step of diagnosis, where do you expect your technology to get used, and how? And why would they do it? They're already making money by this kind of a practice, right? Where is the incentive for them to add a diagnostic step? So it's almost like there is a disconnect between Matrix is one of my favorite movies, okay? Not that Keanu Reeves is a favorite. Matrix is, okay? So if you look at Morpheus and you see, we could either live in this dream world that somehow the technologies that we're developing will get used in point-of-care testing programs. I'm not saying don't dream, okay? We need people like Cepheid. But at the same time, let's be a little real here. If most people are just practicing what is called intuitive medicine, right? Oh, you have this, go home, right? How do we get them to practice precision medicine? How do we get an average provider in a high-burden country to say, I must diagnose before I treat? How do you get them to even wake up and say, there is such a thing called diagnosis? I can't bypass that, or should not bypass that. Yeah, occasionally I realize no diagnostic is helpful. You still need to act, okay? I'm an MD, I understand that. But by and large, you've got to at least try to get a diagnosis. There has to be a step in between. So there's a nice book called Innovator's Prescription by Clayton Christensen. He says, only when diseases are diagnosed precisely can therapy that is predictably effective for each patient be developed and standardized. We term this domain precision medicine. Okay? How do we go from this crazy intuitive medicine reality to precision medicine when somebody says, oh, I think you have TB, get a test done, and come back to me, and if it's positive, I'll put you on the right treatment, so on and so forth. So I'm saying we need to promote the whole field that diagnosis is a good thing to do, right? It's like how all milk manufacturers banded together and say, drink milk, guys, it's good for you, right? Or all the egg manufacturers get together and say, eat eggs, it's good for you. Not your egg, not my egg, just let's promote eggs. All of us will benefit. Let's just promote milk, all of us will benefit. I think all diagnostic companies and test developers should just promote the field of diagnosis, that don't bypass the step. You really cannot afford to be shotgun. There are good technologies available that will help you to precisely figure out what the heck you're treating. I was just talking to Sarah today, and I was telling her there are so many viral infections in India. Half the time, not half the time, 90% of the time, nobody knows what they're treating. Okay? So many undifferentiated fevers. It's like the blind leading the blind. Oh, I'll start you on 3 antibiotics. Right? This is happening every day in India. Can we get diagnostics to improve this mess? Right? And you guys, engineers and test developers, have to do something and not stop there. You've got to promote them too. Otherwise, people will go back to prescribing 3 antibiotics for everything. So with that, I'd like to thank all of you, including San, Luke, Tamina, Beth, and Zelos, and of course, my Berkeley mentor, Art, for the opportunity to come back. Thank you. How are we doing on time?
Perfect. Okay, so if people have questions, keep your hands raised, and we've got volunteers with microphones that you need to speak into for your question. Okay, go ahead.
Oh, who's, do you want me to go? Okay. Hi, I'm here. So, in the case of TB, what I'm gathering from what you said is that if you feel that the issue is more to do with whether something is a real point of care or not, then for drug-sensitive TB or in areas where there's a lot of drug-sensitive TB, then am I understanding that you would say microscopy is the thing that if we had to do something, we should be promoting point-of-care microscopy and forgetting about Gene Expert for now?
No, that is not what I said. I said if you do have microscopy and nothing else, at least make that work as a same-day test.
What have you said that would make me choose Gene Expert over microscopy in such a place? Because you've just told us that, power failures. You've emphasized that the thing you most wanted is to be a real point of care. And then you've told us that, these places are fraught with power failure and all that, but you can have a simple light microscope that doesn't even really need, there's no electricity or anything needed. Like the Zeal-Nielsen needs no power.
Sure.
So, and then for drug-sensitive TB, you're saying the sensitivity is about the same, and the specificity. You're saying in the hands of these the Greens all came up with your microscopy. So, but then you seem to criticize the government for not bringing Gene Expert as a point of care, and I couldn't understand the logic.
Okay, so the goal of my talk was to not really make a recommendation on smear versus expert. That was not really, I was really talking about what a point of care testing program is. I have no question in my mind that a Gene Expert is far more accurate than sputum smears.
Okay.
The question is it affordable and scalable, right? So right now, Indian government will start using Gene Expert, maybe in small groups, and eventually they may scale it up to replace smear microscopy. That's where South Africa is going. So if I had a choice, I would absolutely prefer Gene Expert. But right now I'm saying if smear is all that you have, at least make it work the best you can while we are waiting for better technologies to come in and take their place. And if an expert has to replace smears in India, all of those 13,000 labs have to be upgraded. Right now, Gene Expert will not work there. It may work in a few, but in a vast majority it won't, which means a lot more investment than just the reagent costs. Maybe that's why the government of India doesn't want to go crazy over it, because they know that it's not just the reagents, it's the complete upgradation of 13,000 labs that it's going to take them.
Right, the infrastructure.
The infrastructure.
So,
Hello. Yes, thank you, Dr. Pai, I really appreciated your talk. Having lived in India for 5 years, 20 years ago, and also been on trips with my wife to medical volunteer trips with my wife in India, I've seen this issue of diagnosis as being a real critical problem, that there's not enough people diagnosing and correctly diagnosing. And one of the things you pointed out was the cell phone has proliferated everywhere. People even who are living in huts without electricity have cell phones, and somehow they get their cell phones charged. I don't know how, but and what I've also noticed is sitting here on my iPhone, I can actually, I think one of the most remarkable things that's happened recently is there's an app called HealthTap where I can ask a doctor in the United States any question I want and get an answer for free.
Really?
And so, pardon me?
Really?
Yeah, I can ask. I've done this several times. I can ask if you.
So
just,
who's paying them for their time?
No one. And that's the interesting part. They're volunteering, and they're just motivated by the curiosity. And it's not so that the thing though is that they're not answering a patient-specific question. They're just answering a general question. So I can get like a second opinion, or say, hey, I have this certain pain here. What do you think I should do? And I've really found it really transformative because it seems that there's so much potential for that kind of way to reach billions of people. And is someone thinking about that or working on that?
So I'm already aware of 2 or 3 groups based out of Mumbai who do exactly that. They offer rapid, those sorts of electronic consultations. Not sure if it's very well accepted in the Indian community. I mean, in India, as you know, culturally, everybody is very comfortable with human contact. You try putting in an answering machine in Indian homes, doesn't work. People are petrified that some alien voice is asking them to do something, okay? They would much rather talk to a human being, okay? Well, here, we rarely talk to a human being, right? We don't want to meet them. Even if they're next door, we'll send them an email, right? In India, it's the opposite. So generally, people like to go to that's why they go to quacks, because the guy is there, right? He's there in the village, in the community. He may not be qualified, but he's there to talk to you. Much of the time, he may be practicing rubbish, but he's at least chatting with you. That's therapeutic, right? That's exactly what role they function as. So I'm not downplaying that. I think it will certainly scale up in a country like India. Right now, it may not be widespread because there are lots of local providers who are actually providing face-to-face contact.
So is there a solution involving call centers or some way of using voice as an interface that may overcome this
I'm not
issue?
an expert in that, but I wouldn't be shocked if people are working on such things.
That was a great talk. Without undermining the role of diagnostics, I think when you're talking about India, I think the problem, as you mentioned, is lack of experts in there, like trained professionals. I don't think you can do anything with diagnostics until you train those people there. And I think if you can put some resources towards that, that'll be a better solution than cranking up, eat an egg or drink milk.
Don't get me wrong. That data, many of them were actually trained doctors. A lot of trained doctors in that study who did not even ask a question. So I wouldn't make the mistake of equating training or education with good quality of care in India. Right, but there were a lot of trained people in Delhi. They were also doing the same rubbish, right? Huh?
A lot of patients there. Look at the population.
Right.
Do you think they can actually spend more time?
Just because I'm a trained MD in India doesn't mean I'm doing the right things, or doesn't mean I can bypass the diagnostic step. Even for trained people, diagnosis requires, in India, I don't want to get into it. In medical school, when we trained in India, we were constantly told, you are a super diagnostician if you don't order a test. You are the guru who can see somebody walk through the door and diagnose them to have TB. If you actually ask for tests, you're a failure, right? Here, it's probably the opposite. You don't even want to see a patient. You want to see all their lab reports before you even touch them. There are divergent places. There's a great book by Jerome Groopman, How Doctors Think. Take a look at that. It's a New York Times bestseller. We need to really get into the heads of people and say, how the heck are they practicing? What's going on in their head when they're prescribing without even knowing what they're treating, right? There's a whole another field which we just don't understand. Why and how is such widespread empiric practice so rampant? It's not just India. You think you could go to Pakistan and get any different data, or Bangladesh, or Uganda? It'll be the same old, right? So that's the point I'm making. So it's not just education. It's how they're educated and how they implement. It's the no-do gap, right? I know I should be doing something, but I still won't do it in my clinical practice.